So hello everyone. Hello everyone, my name is Amin Choukou, Associate Professor at the College of Rehab Sciences, University of Manitoba. Please welcome me and join in our speaker from Montreal, Dr. Thomas Tannou. Dr. Thomas Tannou is a geriatrician and an early career researcher who joined the Institut Universitaire de Gériatrie de Montréal in January 2023. He has medical and research expertise focusing on anosognosia, which is self-perception disorder, and its impact on decisions related to aging in place. He's received extensive training in Europe at Université de Bourgogne-Franche-Comté as a physician specialized in geriatrics and as a neuroscience researcher. His work explores how self-perception influences the acceptance of care and services. Through trans-disciplinary approaches integrated the clinical assessments of risk-taken, non-invasive technologies as a support for risk assessment and prevention, and the ethical issues associated with the resulting professional responsibilities. Involved in innovative projects, Dr. Thomas Tannou has led a functional MRI study to better understand the alteration of the neuro-functional processes involved in risk-taking in Alzheimer's diseases, a European survey on the methods used to assess decision-making capacity, and in particular the question of legal capacity and ethics, and a literature review on the effectiveness of unobtrusive technology in supporting the choices to age at home. Dr. Tannou is a recent winner of the AgeWell EPIC AT program, founded by AgeWell NCE, an international prize for recognition in neuroethics. His aim as clinicians and researcher is to facilitate collaboration between research and clinical practice in supporting aging in place for the people living with cognitive impairments. So please join me and welcome Dr. Tannou. Before I get you to present, I will have a land acknowledgement. So just a reminder that we are located at the University of Manitoba campuses that are located in the original land of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis nations. We respect the treaties that were made on these territories, and we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous community in a spirit of reconciliations and collaborations. Dr. Thomas Tannou, it's over to you. So Dr. Tannou is going to talk for 45 minutes, followed by Q&A sessions. It's up to you.
Thank you very much. Thank you, Amin. And thank you, the University of Manitoba, for the invitation. So my presentation will be about the implication of risk perception disorders in technological intervention to support aging in place. As said, I'm a physician and researcher in Montreal. So, is it working? Yeah. So I want to thank again the University of Manitoba and especially Amin that I met in Toronto in the AgeWell conference last autumn. And I definitively want to thank the AgeWell EPIC program. I also want to thank the research team in France and Montreal. Without this presentation would not have been possible, and in particular my PhD student, Charlene, who worked on that project. I don't have any conflict of interest to declare. First, before going deep into the subject, my objective is to share with you my passion on today's topic. I hope that at the end of this talk, you will be convinced by the importance of it. First, to make sure that everyone is on the same page, I want to make sure that when we talk about neurocognitive disorders, we are all talking about the same thing. We are talking about cognitive impairments, so impact at least at memory, noise, language, pre-access, executive function, that can be objectivated by specific tests, that have a slow evolution, which differentiate from delirium, and that impact on daily living activities. The main and most frequent illness is the Alzheimer's disease, When we talk about Alzheimer's disease, very often we think about the clinical impact and the dementia stage. But in fact, we have to remember that Alzheimer's disease is a long-term evolution of neurodegenerative disorders, which start grossly 10 years before the first clinical symptoms. And our strategy has to be declined between primary prevention, which is more in the field of public health. Then when the first biological marker increase, our goal is to delay the clinical impact. And this is the target of new medication that will be shortly in the market. And then, and it's where we as clinicians have generally the first impact in the tertiary prevention, where our objective is to slow down the cognitive decline, to improve activities of daily living, and to adapt care plan. And finally, we have the late stage where we need to have symptomatic and palliative care approach to take care of the dignity of these people. Why do we have to focus on the impact on neurocognitive disorders? Because this impact has said executive functions, but also, is it fine? Yeah, we have some mic troubles here, but it impairs executive function. It impairs the limbic circuits, so the emotional state of people experiencing Alzheimer's disease. It impacts memory impairment, and this leads to what we call anosognosia. Anosognosia is a specific symptom that is sometimes mixed with denial. In fact, anosognosia is the consequences of your memory impairment. When we talk about memory impairment, we don't talk about the incapacity to use your remembers. We talk about the incapacity to create new memories, to record new information. And so because you don't record new information, you don't record the fact that you are not able to remember things. And because of that, you have some questionable, we may question your ability to make appropriate decisions, not because you don't do decision, but just because your decision rely on biased perceptions. You think that you're capable of things that you're not capable to do anymore, but you have the feeling that you're capable to do it. When we talk about decision-making capacity, what is it? It's a four-stage process when first we have to evaluate possible option. Do I want that or that? Then we need to have the balance between the benefit and the risk. I want this ice cream, but there is a hard risk that I will put a part of the ice cream on my shirt, which is not good for this presentation. We have to be persistent in the choice of an option. If I say yes to you, Amin, and no to you, Lilian, this is not a choice because there is no persistence. So the influence of other people does not guarantee that your choice is a real decision. Choice and decision-making are not the same. And finally, we need to implement this into action. If I say, yes, I will give you $10, but I never gave it to you, it's not a full decision-making process because I don't go to the end. During aging, we have a lot of decision-making process. As you may understand from this presentation, decision-making skills are essential for autonomy. And older people faced a lot of complex decisions, such as anticipating an inheritance, such as choosing medical treatment, such as choosing where to live. Aging in place, going to an institution, it's a very important decision. And we ask people to do this even if they may be impacted in their decision because of Alzheimer's disease. Why do I want to focus on risk-taking? Because, as said, Alzheimer's disease is not a question of memory, in fact. It's more a question of adaptability. If I don't remember my real condition, I don't do the right decision concerning my own condition. So we know that with cognitive impairment, we have an increased subjective risk. We are at risk of fall. We are at risk of getting lost. We are at risk of many things. But because of the anosognosia, our risk perception is reduced. And so there is an imbalance that can lead to risky and inappropriate decisions with serious consequences for the health and for the future of older adults. This is very important, even for me as a physician, during my geriatric clinics. I don't know if you're familiar with the 5 M's of geriatrics, but when we made a geriatric evaluation, we have to focus on medication, we have to focus on mobility, we have to focus on mind, mood, depression, delirium, so on. We have to focus on multi-complexity, multi-morbidity, heart, lungs, everything. But we also have to focus on what matters most for our patients. Because we need to know in which direction we need to orient the care, the specific care for our patient. And for that, we need to make sure that if it's important for my patient to go and ski every weekend, even if he's 55, I will propose a knee surgery because it's something so important for my patient. It's that makes sense for him. So we need to understand what matters most, but this has to be consistent with his own and real condition. So we need to assess the risk. But what are the challenges of risk assessment? Challenges are linked to responsibility. As people, we want as much as liberty and freedom as we can. We want to do everything we can. But as healthcare professionals, we want to reduce risk because we want to protect our patients. And this creates a conflict. If I let my patient increasing his risk in order to protect his liberty, I may feel responsibility. I may feel responsible if something wrong happens. But if I increase my risk protection, I decrease the liberty of the older adults. And this has to be seen within the context of aging in place. So, as said, what's the point in targeting the notion of risk in decision? Finally, risk-free decision does not involve responsibility issues. We're okay with that. But voluntary risk-taking requires risk awareness. You need to understand which kind of risk you are ready to take. And one person risk-taking is likely to affect one other right. If yesterday I decided to take some risk with the shuttle of my plane, and if because of that, I missed my plane, my colleagues here would have to manage this. So each one decision impacts other. So the question we will try to answer right now is how to ethically support risk decision-making in Alzheimer's disease. First, we ask how clinicians assess the ability to make risky decisions. We made for that an online survey through the European Geriatric Society to understand how geriatricians evaluate decision-making in their patients. So it was an online questionnaire, and the profile of the respondents from nearly all the European countries were, for half of them, early career professional, but half only, so we had all the range of career, and 34 had additional training in neuropsychology. They mainly work on acute care or outpatient practice, and many of them had academic practice, at least teaching. And which is important for the next stage of my presentation, nearly half of them had regularly to produce legal reports to the court. So it's not just evaluating decision-making capacity as a theoretical condition, but it may impact the legal capacity of the patient. And all of them had experience in managing patients living with dementia. Okay? When we ask them, how do you identify cognitive disorders? They mainly use screening tests, such as Mini-Mental or MoCA, or both. And they evaluate daily skill capacities with scales, activities of daily living or instrumental activity or daily living scales, completed with caregivers and or patients. They rarely ask occupational therapists to evaluate this, and when they do it, it's mainly in simulated environments and in few situations, in real-life situations. The assessment of anosognosia was not often done, only a third, and generally speaking, it was done during informal interviews, like clinical informal interviews. We asked them how they routinely assess the patient's ability to deal with risky behaviors, and they said that they use informal interviews many times. Sometimes they use the screening test, and rarely they use specific neuropsychological assessments. But when we ask them, what kind of dysfunction do you consider as red flag for everyday risky decision-making impairment? They mainly said anosognosia and dysexecutive syndrome. Which is interesting is they do not assess this in their routine practice. As said, they use mainly Mini-Mental or MoCA, which are not great for dysexecutive evaluation, and they do not use formal evaluation of anosognosia. We also asked them an open question, like binary. For patients with dementia who may have impaired decision-making ability, would it be for you more acceptable to allow them to make risky choice to support what matters most, for example, staying alone at home, or would you prefer to convince them to make a safer choice? Of course, it's binary, but it was an open-ended question. Our objective was to have kind of nuance in it. And the answer shows that we can support risky behaviors depending on the degree of risk, depending on the level of impairment, depending on the persistence of choice and behaviors comparing to previous life. If you with someone who always took risk during his life, there is no major change compared to someone who never took risk and somehow, at some point, started to have risky behaviors. Okay? Of course, as said, because we do not take decisions just by our own, decisions impact others, we need to make sure that the decision-making process is shared with the environment, the caregivers, the professional, to make sure that the environment is safe. And finally, we need to review decisions frequently. So, in everyday practice, thank you, clinicians mainly use screening tests and their clinical sense. They had recognition of the essential role of individualized approach and taking into account the living environment. But they show the complexity of legal issues, and they refer to the UK Mental Capacity Act, for example, and the complexity of ethical issues in balancing risk and safety. As they say that they use screening tests to assess risk-taking, we were wondering, can risk-taking be assessed using common screening tests? So we have made a behavioral study. I will go quickly through this. But the aim was to see if one oh, sorry, there is a mistake here. One screening test, the MOCA, is sufficient to assess risky decision-making. To see that, we wanted to search a correlation between the MOCA and two tasks that have been designed in neuropsychological studies. One is the BART, Balloon Analog Risk Task, and the second is the Iowa Gambling Task. These two tasks are not used in clinical practice. It's research task. But in these two tasks, you are asked to take some risky decision, and you have to learn from your experience. And we wanted to see if there is any correlation between this task and the MOCA. But of course, we also need to, I don't know if it's working still, but we need to make sure that this behavioral task, no, I have feedback, it's fine. We needed to make sure that we had a correlation between these two tasks for scientific reliability. So the methods, we included patients over 70 years old with mild to moderate cognitive impairment. We perform with them the MOCA, the frontal assessment battery, the trail-making test, the Stroud Victoria, and the judgment assessment tool, and the two tasks we talked about. I just want to present for you this task. The one, the classical BART, you have to pump balloon. You have to have as much point as possible, and bigger is the balloon, bigger is your reward. But higher is the risk of explosion. And if the balloon explodes, you don't have your points. So you have to find a balance, and you have 15 trials, okay? And the Iowa Gambling Task, we simplified it into a binary task. So you have two different cards, and you have to choose each trial if you want the red or the blue. The red gives you more points, but less often, and the blue gives you less points, but more often. And trial after trial, you have to learn that finally, the more advantageous choice is the one that has the less points at each trial. But you have to learn it. You don't know the rule at the beginning. So we had, generally speaking, geriatric patients. I mean, we had participants age over than 80 with 21.2 mean MOCA score. So it was a geriatric population with neurocognitive disorder in a mild to moderate stage. Our results show no significant correlation between MOCA and the two risky decision-making tasks. We had no correlation. But we found consistency between the two tasks, which is great. And we also find consistency with tests targeting frontal function, mainly flexibility. So decision-making, it's maybe more linked to flexibility than to MOCA, in fact. So in conclusion of this behavioral study, assessing risk-taking decision-making cannot rely on simple cognitive screening tests such as MOCA. I would not say that you should use BART or IGT to screen decision-making. It's not done for that. I want just to say that MOCA score, it's not a good score to say my patient is capable of risk-taking or my patient is not. So we need to integrate specific tasks, as risk-taking is probably a specific skill. And the complexity of this type of global assessment called for innovation in assessment method. I will not go through it, but as said by Amin as an introduction, we worked in neuroimaging techniques like EEG and fMRI to see if with the same task and the same patient, we were able to see any difficulty in or any biological markers of cognitive difficulties in decision-making process. And our preliminary results are quite interesting in showing reward processing impairment, probably linked to memory difficulties. But I will not go through this here. So, based on these behavioral results, we ask ourselves, are seniors anticipating the risk associated with aging in place in case of neurocognitive impairment? In that study, our objectives were to identify the factors taken into consideration by older adults with a diagnosis, and I insist on it. All our patients I will speak about just after had diagnosis of major cognitive impairment, at least at mild stage, when considering the question of place to live for the near future. We have done it with qualitative methodology using semantic discourse analysis, and we collected data until data saturation. Okay? So we also wanted to describe the population, and so we have done evaluation of neuropsychological function, evaluation of anosognosia. We had patients and we had pairs, binôme. Do we say binôme? Binôme? We had pairs with patients and caregivers, again, corresponding to geriatric population, with diagnosis of Alzheimer, late Lewy body dementia, vascular, or mixed dementia without dominance. From the results, everyone shared an objective, which is aging in place. And what for? For the other adults, they say that it they want to maintain their environmental stability. They have emotional attachment to their house. Their house is their reference point, and they feel that they have the right to live there. One said, I hope to be able to stay at home as long as possible. I have been here since 40 years. For the caregivers, the same, exactly the same. Maintaining environmental stability, emotional attachment, reference points, rights, they say the same. We have decided that we will do everything we can to keep her at home. She has her dog, she has all of memories in this house. But when we focus on distinct discourse, the older adults, when they talk about risk that we can assess, risk that occupational therapists can assess at home, they mostly underestimate it. One said, sometimes on my gas, I forget that I have put something on cook, so it burns, and she loves. I repeat, they had diagnosis of cognitive impairment. And when we ask them, they explain the willingness to live in the present. There is a lack of anticipation of the loss of functional independence, despite the fact that they have medical follow-up for their cognitive impairment. So they say, I haven't considered the problem yet. So they precisely describe that there is no risk if they stay at home. Whereas when we ask the caregivers express the willingness to anticipate loss of functional independence. So caregivers can see what the future can be. They say that there is risk day to day, risk of fall, risk related to food, risk related to medication, risk related to vulnerability. So they say that staying at home provides a secure environment. Sorry for the... but for that, we need to reorganize the home. We need to install warning devices. We need to provide formal and informal assistance. We need to implement protecting measures, such as banking protection, such as mandate, and so on. So you can see that finally, choosing the right place to live for the older adults means staying at home because this maintains their internal security. Finally, what we can feel as a risk. For them, it's safety, because home is safe. They feel it like that. Whereas caregivers have dilemma between right and security. They have the right to stay there. It's their liberty. But we have concern as caregivers about their security. And so is aging in place is a priority solution. It needs to be to go with an environment that is legally and materially secure, with physical presence, as caregivers said, of range of home care professionals. So, if we summarize it, caregivers have the perception that there is a need for anticipation and need for assistance to the older adults, but also to them. Whereas older adults show that they do not feel they need assistance because of the lack of adaptability, because of the anosognosia we talked about. And so there is kind of conflict between the safety, which is for the older adults as nothing changed, whereas the need to anticipate the evolution as caregivers can see it. It is therefore necessary to find adaptive solutions that allow to anticipate risk without changing the functioning of daily life. And so the final part of my presentation is, can unobtrusive technologies meet the needs of older adults who want to age in place? We have made for that an umbrella review. Why focusing on home-based technology? Because what we can call smart environment is at the intersection between service provided by the Internet of Things and the physical location where the older adult lives. And the objective of smart living environment is to provide holistic support to older adults by detecting critical situations and or providing assistance. Okay? We wanted to focus on unobtrusive technologies because unobstructive technologies, sensor-based technologies, have the capacity to be completely integrated into the environment and do not draw the user attention, do not demand their direct involvement. So unobtrusive technologies seems to be preferred by older adults. And they are particularly well suited for older adults with cognitive frailty or cognitive impairment. On that topic, we had extensive funding. For example, here, more than nearly 50, I'm not good at English numbers today, nearly 500 millions of dollars spent into the development of environment, smart living environments for older adults in the last 20 years or 50 years here. And if we look at the results from the literature, the effectiveness of smart living environment in supporting aging in place remains clearly unclear. So we have done an umbrella review protocol. An umbrella review is a review of review. For those who are not friendly with that. So the objectives were to document the effectiveness of smart living environment to support aging in place and to gather evidence on what factors and strategies were identified as influencing the implementation process. Here is a flowchart. We finally included 17 published reviews that covered nearly 200 district primary studies with a very low overlap, which means that few studies from one review were included in another review. Very low rate. If we go to the results, what is the effectiveness based on our literature review? there is low to moderate effectiveness of these technologies to support aging in place. And effectiveness appears to be strongest in the capacity of recognition of activities of daily living, which means that technologies are good to recognize what you are doing as a daily living. If we go deeper, direct measurement of quality of life, direct measure of health, sensor-based assessment for activity of daily living, sensor-based assessment of frailty, sensor-based prediction of cognitive decline, and sensor-based prediction of risk of falling were the main topic found in the literature. But the evidence that we had capacity for that were good only on green here, and not good when it's orange. Okay? So, are we effective on it? Not quite. But as it's a literature review, we need to ask what is the level of our evidence based on literature review to affirm these things. We have a very low level of evidence because of very low methodological values of the primary studies and very poor methodological quality of the literature reviews. We have two steps. First is the primary study, and second, because we have done a review of review, so we have the two steps of methodological limits. And the quality of literature review, same way to present it, orange is low, yellow is moderate, and green is fine. And if we compare with the effectiveness, you can see that we don't have many things to affirm what we said previously. So what was interesting was to see the main challenges described in the literature review as challenges for technology adoption. And we can say that there is a lack of functionality, there is a lack of usability, there is a lack of demonstrated efficacy, and what is expected for, for other adults is not easily achievable. But we also can tell from the literature review that there is facilitators to implement smart home environments. And the main facilitators are the use and simplicity of the use of the information from the sensors and the fact that sensor requires little attention. So as said, sensor-based environment is particularly well suited for older adults with cognitive impairment, which is good, which can help us to go in that way. So in the discussion, we have, based on our literature review, low to moderate effectiveness to support older adults to age in place with this kind of technologies, but these results must be interpreted in the light of the low level of evidence. Most reviews conclude that unobtrusive technologies are not mature enough for risk pro-adoption. In discussion, we have seen that high number of unobtrusive systems does not go beyond proof of concept or pilot stage, which does not allow to meet the specific needs of older adults. The lack of implementation studies also limits the possibility of wider adoption of this technology in real life by the person primarily concerned, namely the people living with cognitive impairment in the context of aging in place. May I say that actually it's like primary studies had the objective to support the capacity to be on the market more than to answer the needs. We need to think how to combine both to make sure that we have products that can be on the market. It's the objective of these technologies, but to do that in answering to the needs of the older adults and not on the caregivers that may be experimenting burnout and so that may be ready to buy things just to help them. We need to develop solutions that focus on older adults' need and support, and being aware of the low level of evidence right now. If you want to know more about it, here is a reference of the paper we published. So, in conclusion of this talk, I want you to remember that risk-taking capacity in Alzheimer's disease is a very important topic. And we need to be aware of the fact that we see, as a healthcare professional, Alzheimer's disease as an increasing risk situation when talking about aging in place. But because of anosognosia, patients have a reduced perception of this risk, and so they may not understand our argumentation. They do not perceive their daily living situation as a risk, as for them it represents their internal security. So, as the question was how to ethically support risk-taking in Alzheimer's disease. Oh, sorry, I have a few mistakes on the slide. So, first, we need to better understand older adults' needs. And because the spontaneous perception of older adults is potentially insufficient, as he refers to his or her internal safety, we need to make sure that we can answer to his willingness to live at home and at the same time protect him for any risky situation. We need to objective specific behavioral risk-taking. We need to assess what is really the most important needs for our patients, but we also need to assess what is really risky. If I want to say to my grandmother, you cannot stay in your own home because of your stairs, and you may fall on them, but maybe she never used the stairs. So we need to assess the reality of the risk before trying to protect for risks that maybe are not there at all. And finally, we need to co-create customized solutions that can manage respect for their internal safety as well as caregivers' sense of responsibility. Do we think that smart homes can be a solution? Yes, I think so, because it could enable to monitor activities and therefore identifying real and not supposed risk-taking situations. It can help to target specific intervention in the event of risk-taking, and so to promote safely aging in place. So as a key message today, we should change the way we look at risk assessment, which shows we made to see the adaptability impairment as a forgotten parameter, and we need to see risk-taking as a daily challenge that needs specific assessment that can be conflicting with older adults' perception of internal safety, and we need to integrate the complexity of living environment. As a conclusion, impact our daily life. We ask older adults to adapt on a new environment, such as nursing home, saying that it's safer for them. But probably, we may adapt their environment to the real risk, to respect their internal safety. Thanks, and if you have any questions.
So we have maybe 12 minutes left for questions. People over Zoom have questions. Bravo, Thomas. Thanks so much for this wonderful presentations. I believe we still have another 10, 12 minutes left for questions and answers. I see here Lisa Engel want to ask a question. Go ahead, Lisa.
Hi, I see that you can see me on the screen, so I'll show my video. Thank you very much for this presentation. It has a lot of crossover with my research in financial decision-making, but from people living with brain injury perspective. So I was wondering, great information that you gave. I have two major questions that I'm wondering if you've come across is the perception of risk, and whose perception of risk do you go by? I appreciated highlighting how those risk assessments weren't necessarily indicative of the daily risks that people take or could take. And what we see in financial decision-making in our studies is who gets to make the decision about what is risky versus what is not, because it's oftentimes what we're asking people to make decisions about are very value-laden and personal, inter-individual differences in the values that they have. So if you could comment on that, and then I have to go grab my notes from behind me because I forget my second question, but I think it was a follow-up. So could you first comment on how you kind of look at whose perception of risk and creating an idea around that?
Thanks. Sorry, I will just to be able to answer to your question, I first need to be able to talk. So thanks for that question. It's very interesting, and I know that financial decision-making, there is a lot of specific literature on it, because it's not exactly the same as other kind of like daily living decision-making. Or so we did not observe exactly this on our studies, because we focus on aging in place question mainly. But what we can observe, and we had data on the interviews on it, because during interviews people talk a lot, which is interesting. We can say that there is kind of transition of decision, like even if people living with cognitive impairment does not say that they have decision-making difficulties, they may feel it, they have the perception of it, and so they naturally transfer the decision to their caregivers. They say, it's complicated, I just see this with my daughter, or just see this. If we ask them directly, and I do it in my memory clinic, I mean as a physician, if we ask them directly, they say, oh, I'm able of it. It's just, they may pretend that using internet now for banking transaction is complicated, and they prefer refer on their children for that. So they will not necessarily say that they are not capable to manage financial difficulties, but in practice, they don't take financial risk. They rely on their caregivers and families. I don't know if I exactly answered to your question, but
kind of. I also personally have aging parents who are just for visiting, and just more even taking it out of finance about whose perception of even a fall risk there is can be very different between individuals. I have a 60-pound dog, and I hate my dad coming and walking my dog. But he sees no problem with it. There's no risk to him, and all I can see is my dog taking off and my dad also taking off and his hip also then being broken. So like our perceptions of risk in that situation are very different, but it's really hard to say who's right? Because oftentimes the risk, there's not even a right choice. Or how would you rectify that in a research or even clinical about who gets to decide what's risk and what's not risk?
I see your question, but I think we need to be very careful of that when we do research on risk-taking. There is not good risk and bad risk. There is risk that you can assume and risk that you cannot because you don't understand the consequences of your choice. When we use BART or IGT in our neuroimaging studies, we were not interested in the results of the IGT of the BART. We are not interested in knowing if the people is a high-risk profile or a low-risk profile. We are interested in understanding if the consequences of the real consequences of the decision are understood. Namely, are you able to take risky decision? I mean, are you able to assume the consequence of your decision? Which is not the same as deciding if it's a good risk or a bad risk.
I totally agree. Thanks for that discussion on it. And I think you started to address my other question, and I see there's a question in the chat, so I don't want to take too much, but how you noted the difference between implicit awareness and explicit awareness, in that people sometimes change their behavior without actually explicitly verbalizing that awareness or the identification of risk, but they may change their behavior. So that was my second question around the differences in implicit versus explicit awareness and risk appreciation. But I will defer to the chat question because I don't want to take up everyone's time for the questions.
Thanks for your question.
Thanks, Lisa, for your question, and thanks, Dr. Toma, for your answers. We have a question here in the chat. I'm gonna read it. So it's a question from Diwaya Taur. She said, or he said, they said, thank you for sharing this interesting research. Due to the current pressure on healthcare system, there is often limited time and priority given to quality of care and sensitive assessments of older adults. There is high reliance on the MMSC by MDs, the physicians, because of time pressure for clinicians at the early stage of diagnosis and adjunct use of the MOCA with limited sensitivity and specificity. Caregiver and family knowledge are often underutilized. You have found history taken an assessment of family caregiver experience, such as market changes in personality behavior, correlates with biomarker evidence and diagnosis of anosognosia. Anosognomia? I don't know this.
Anosognosia, I think it's...
I know the person. I think the person means anosognosia. How can assessment of that word? Perception awareness be used to make shared complex decisions on levels of cognitive impairments for clinicians and family currently? Sorry, the question is a little bit long, so probably I can leave it here for you.
Thanks, but I think I mainly understand your question. Thank you for this question. And you're right, there is time pressure on health system. And we need to find a way to better integrate the experience from caregivers and from patient history. And probably tests have to be used as tests. I mean, it's interesting to have the follow-up of MOCA or MMSE within time to see the evolution of cognitive impairment, but we should not rely on it to make diagnosis, not even from cognitive disorders diagnosis, but for the anosognosia specifically. What is difficult is currently, for clinical practice, there is no scale that is completely validate to evaluate anosognosia. I presented in the slides the anosognosia questionnaire for dementia. It's a list of 30 questions, such as do you find your way in your tone? And we ask separately the patient and the caregivers. The patient, we ask to complete it from never to always. And we do the same for the caregivers. And we compare it. Never is 1, always is 4, and we subtract the score. And anosognosia scale is when you have high difference. As same as we said for risk-taking, the question is not, do you lose yourself? The interest is not on it. The interest is, do you have the perception, and do your perception correlate the perception of your caregivers? Limit of these scales currently are that you compare 2 perceptions and you figure out that the perception of the caregivers is the right one. But maybe I have the perception that my grandmother uses her stairs every day, which is maybe not the case. So comparing perception and perception does not give us a specific sense of the answer. So it's tricky to evaluate anosognosia right now, and we probably need more research on it.
Thank you. I see some thumbs ups in the chat. Thanks for everyone. Thank you, Diwara, for your question. Do we have more questions in the room? I will try to scroll here. We have Anna Andrianova here saying, thank you, Dr. Toma, for your insightful presentation on anosognosia and its impact on aging in place. It was very enlightening. Thank you, Anna. Diwara is just thanking you.
Thank you very much.
We still have a couple of minutes left here, so I will have questions. I think it's my right today. Thinking of unobtrusive technology, and you know you are doing a couple of some work in Montreal and in Europe about it. I have a question for you as a researcher and also as a doctor, as clinicians. So as a researcher, how if you give us if you describe your context, how you are using an obtrusive technology in your context for research purposes, and as clinicians, how are you imagining the future moving forward? Is it like decisions, or is it like a prescription by a clinicians that has to be made so that we implement technology in people's home, or is it like collaboration between many clinicians and family? How do you think about all that?
Thanks for your questions. I will first start to answer to the question of the research context. We are working in Montreal within the Côte Saint-Luc Living Lab with Nathalie Bière, Mélanie Couture, and so on. And we work on implementing sensors in home of older adults living with some kind of cognitive impairment, and these older adults has to be flagged by social services. So social services wants to implement some home care, professional cares, and the objective of the monitoring is to see the results of the home care services and advice is given, and to see if we achieve the clinical objective, if we improve mobility, if we improve and so on, and so to adapt clinical and caregivers, professional caregivers support to the reality of the older adults. So this is the Côte Saint-Luc, one of the Côte Saint-Luc Living Lab objectives. For your second question, there is two things that came up to my mind. First, as a physician, I have some difficulties with supportive technologies. When I have to prescribe medication, I know, because of international guidelines, I know that in this situation, this medication is the one I have to prescribe in first line, and if it's not working, the second line is that medication, and depending of the laboratories, and just this family of medication is the one I have to implement to my patient. But I can trust it because of guidelines, because of RCTs, because of for technologies, there is not this kind of general guidelines and marks that we can rely on. So I don't know. It's on the market. You can buy it on Best Buy, and I don't know how I can trust the technology, and so I don't know how I can advise my patient and families to use it for their everyday needs.
Very thoughtful. Thanks so much, Dr. Tannou. I think it's time to close this session. So I want to thank the College of Rehab Sciences for helping Dr. Toma join us here, and the AGL EPIC-AT program for encouraging speakers from across Canada to come to us and speak about their fascinating research. Thanks so much, Dr. Tannou, once again. And thanks everyone for joining us here in person or remotely through Zoom. And have a wonderful day and happy year, everyone. Bye-bye.
Thank you.